Today's episode of This Is Getting Old, Moving Towards an Age-Friendly World has been sponsored by the George Washington University School of Nursing. Welcome to This Is Getting Old, Moving Towards an Age-Friendly World. I'm your host, Melissa Batchelor, and today we're going to be talking about nurse practitioner school and what adult gerontology acute care nurse practitioners actually do. And I'm very excited to be joined today by Dr. Linda Briggs, who's the program director for the Adult Gerontology Acute Care Nurse Practitioner program at GW, and Helen Brown. So before we begin, I'll let you guys introduce yourselves.
Thank you. So my name, as Melissa said, is Dr. Linda Briggs, and I'm the program director. I've been a nurse practitioner for about 26 years. My specialty is predominantly cardiology, and I have taught and worked at hospitals across the DC metro area with cardiac surgical teams, with cardiology interventional folks, and also with hospitalist teams in the Maryland, DC, Virginia area.
Okay, and Helen?
And I am Helen Brown, and I am a adult acute care nurse practitioner, as well as being a family nurse practitioner. I have been a nurse practitioner for the past 25 years. Actually, Dr. Briggs was one of my mentors and teachers through my nurse practitioner acute care program back in maybe I shouldn't tell secrets, but 1996, 97. I was primarily, prior to becoming a nurse practitioner, I was a critical care nurse. I worked in multiple types of venues, mostly in smaller suburban and rural hospitals. So that is a population that I have always found very interesting and very challenging, of the kind of the non-tertiary, but still can be very sick individuals. As I completed my program, I was offered a job in an emergency department. And I have to be honest and say at this point, I never would have thought I would have at that point been hired or worked as an acute care NP in an ED. However, I felt that I needed to broaden my ability to develop differential diagnosis and to analyze and care for patients. And so I accepted the job and fell in love with emergency medicine and being a nurse practitioner in the ED. I watched the ED where I worked for the past 24 years grow from being a small, kind of very suburban in the Annapolis area into growing to the largest, the busiest emergency department that is in the state of Maryland. It was a diverse practice, and I grew with every step of the way. So when you say as a nurse practitioner, it's lifelong learning, just as it's lifelong learning in nursing, it is 100% true. I loved being a nurse. I loved being a nurse practitioner, and I loved my job in the emergency department. So I found myself very, very fortunate. So I'm hoping that if you're interested in this field, that maybe we can stimulate some interest for you to go back and end up with rewarding careers like Linda and I have had.
Okay. All right, so let's start with our first question. I do appreciate the nod there towards lifelong learning, because part of this podcast is around age-friendly initiatives, and lifelong learning is part of that. So let's talk about what adult gerontology acute care nurse practitioners do.
So adult gerontology acute care nurse practitioners, and we'll use AGACNP to make that mouthful a little shorter. They care for the sickest of the sick. They care for physiologically unstable, technologically dependent, and highly vulnerable patients. So most often you'll see them working in settings like emergency departments, ICUs, maybe urgent care. And what we do typically is we're working as part of a team, which includes doctors, nurses, and other kinds of specialists. But we're independent providers. So we function very similar to some of the doctor counterparts on the team, which might include residents and interns and so forth. We assess patients, we make diagnoses for what's going on with them, we write orders, and we treat patients. And we do a lot of education, both of patients and of staff as well at various times. Helen, do you have anything you want to add to that?
The primary focus of the AGACNP, the population-wise, is going to be on the adult and the geriatric patient. And I think that's an important thing for someone who is interested in this particular specialty as an NP to understand. So we can take care of individuals that would start at about the age of 17 all the way through to the geriatric patient. And I think one of the important features of the past 24 years that I've seen is our increase in the geriatric population, as well as our need to grow and understand that population and be able to see their vulnerability. And in my world of emergency medicine, being able to create care that is, I won't say specialized, but certainly meets the demands of that increasing population. But you can't forget that the opposite side is there, and you have to understand the young people too. So you have to understand the adolescent and how to approach that late adolescent and young adult. So it's a very interesting dichotomy between the two populations and then everybody else in the middle.
Right. And I think most people get younger and middle adults. It's the older adults that often are not included. So there are geriatric emergency departments, there are age-friendly health systems, which include the 4 M's. So anybody going into acute care or healthcare at all really should be aware of how to take care of older adults, since they will take up 60% of hospital beds in every hospital in this country. Yeah. So we talked a little bit about places that they practice. Did you want to say anything more about where?
Yeah, so one of the things that particularly the American Association of Critical Care Nurses emphasize is that care is not setting specific. It's based on the needs of patients. So it's all around what the patient needs. And again, it's more around that physiologic instability and potential for complications, et cetera. So traditionally, they work, AGACNPs work in the hospital, but you can see them in hospital outpatient clinics. You can see them in urgent care. You can see them in rehab settings, in long-term care as well, because they have that adult gero background. And you might see them potentially in ambulatory surgery centers too. So there are a lot of places where AGACNPs can work besides just in the hospital.
Right. And so with the adult gero nurse practitioner, we're talking about acute care, but there is a primary care track also that we're going to be talking about on another podcast. I'm actually a family nurse practitioner that's only ever done geriatrics and long-term care. So being a nurse practitioner, you are a generalist when you graduate, and then you specialize, just like you said, if you're going to work neuro or cardiac or the emergency department. That's true with any our baccalaureate degree and master's degrees. So go ahead.
There are setting specific or the population specific requirements. So the adult gerontology is split in between primary care and acute care. And so their education and their degree will actually specify that it's adult gerontology acute care or adult gerontology primary care. And the primary care folks would work with folks that they're seeing over a long term. So it would be a patient that they might follow for several years coming into their particular office, where the care that we provide as AGACNPs tends to be more episodic, related to a particular episode of health problems. So somebody coming into the emergency room, somebody having an MI or a stroke, or having cardiac surgery or a cardiac surgical, a stent, that kind of thing might be why they would come in and we would be seeing them. Helen?
There's another population or sector that I think acute care, adult gerontology, acute care NPs are entering into, that are creating a niche that I think is very needed. And that is in the physiologically unstable patients that are being discharged back to their homes. And what our goal is to try to provide a quality of care for them and decrease their time in the hospital or time to readmission. I think one of the populations that comes to mind is the heart failure population. And I'm sure in your world of geriatrics, you realize that the fine tuning and things like that needs to take place in order to sometimes provide quality life for these individuals. And acute care NPs are well suited to bridge from when they are discharged from the hospital and they go back into their home, and we're handing the care back over to our primary care colleagues and bridge that gap so that we can hopefully get them through a period of time and to stability so that they have quality of life and don't end up having problems and ending up coming back to the ER again with their recurrent heart failure. And that's one population, but there are others out there that you can see that are people who have really acute problems that are chronic in nature too. And that ACNP interface with the primary care physician and or a nurse practitioner can really make the difference in keeping people within their home and bridging that gap. And many of the advanced heart failure, as well as some of the other surgical kind of practices and things like that, are really using acute care NPs to bridge that gap.
Right. And I think as you talk about that, I'm thinking about the transitional care model where, there is follow-up after someone is discharged from the hospital to prevent that kickback readmission. And actually just recently did an interview with Dr. Pam Cascione, who's developing socks that monitor heart failure. So that's just another way that, nurses, she's a geriatric, forget her exact title, but she's a nurse practitioner, but she's faculty at Penn and is doing research, but also creating new technology to help people stay out of the hospital and detect heart failure earlier. Well, speaking of technology, let's talk a little bit about the role of simulation, and then we'll come back to talking about salaries and other things about our program. So
ACNPs need to be able to think on their feet and respond very quickly to changes in patient conditions. So one of the things that we do to help them be able to practice thinking on their feet and making critical decisions in a very expeditious way is simulation. And we have at GW a state-of-the-art simulations lab where students can practice assessing and diagnosing critically ill patients. We have scenarios, a lot of them from Helen's practice in the ED, that they can work through. And so they make the diagnosis such as septic or cardiogenic shock, or maybe it's an arrhythmia, or maybe it's a patient who's had surgery and they're volume depleted and they need volume resuscitation. We have a multitude of scenarios that students have to work through, and they each get a chance to be the team leader, direct the assessment, and then determine what things they want to do for that patient. So we spend a lot of time in the sim lab, and that's something that students really, really enjoy.
The George Washington University School of Nursing has 3 highly ranked online master's program options to help you get there. Check out our Adult Gerontology Nurse Practitioner in either acute care or primary care, and our Psychiatric Mental Health Nurse Practitioner programs. All 3 are in high demand with excellent starting salaries. Applications to start our programs in the fall are due each year in May, and to start in the spring, applications are due in October. You can learn more and get exact due dates by visiting our website, nursing.gwu.edu.
And our ability to place students in precepted roles for their clinical experience, it's going to depend on what preceptor is available at what site. And so therefore, we can't give all students the exact same type of clinical rotation that would, I guess, from my perception and Linda's, would be ideal. We do the best we can. However, everyone may not get this exact same clinical experience. They'll all get the good clinical experience where they gain the expertise in being able to assess and diagnose, manage, intervene, consult, admit, discharge. They will get all of the experiences that they need, but they're going to be varied. What simulation does is allow us to identify low frequency, high acuity type of situations, any AGACNP may have to face and be able to work through it in a simulated manner. And so therefore it becomes almost a baseline or an equalizer among all of the different clinical opportunities that our students have. And I think that simulation is an excellent way to help conquer that gap. It also takes some of the element of when you first go out into practice and you're uneasy. At least I was very uneasy when I first started my clinical practice and thinking about what was I going to face that day, and falling back on some of the simulation and things that we did and saying, you know what, I may not have seen that when I was a student, but I did take care of that in the sim lab. And I remember some of the things I needed to do. And so simulation can help give a certain degree of comfort level. For our students that just are starting and going from bedside nurse and taking their first clinical practice, what we can do with simulation is we can simulate caring for a patient, getting them to feel comfortable with just the interviewing process, so that when they first go into that first day in clinical, they don't feel like they're going in just cold. They can go in and have at least say, okay, with simulation, I did practice on how to interview a patient with this kind of a problem, and I can take that particular skill set and bring it over here and apply it. So simulation does a lot. It's really bridges a gap that I think in all nursing education, undergraduate as well as graduate, for acute AGACNPs, as well as family practice nurses and our primary care colleagues.
Right.
One of my favorite stories is about one of our simulations in which the patient had a beta blocker overdose, and the students had to work through what to do with that. And the answer is they're going to give the patient glucagon. Well, we did that scenario with the students, and shortly after that, and following graduation, that student was in a setting where a patient actually did have a beta blocker overdose. And she knew exactly what to do because she had done that in simulation. And everybody was absolutely awestruck that she knew the answer to this question and was able to effectively treat that patient. So that patient actually benefited from her direct experience in the simulation lab.
Right. And I think, the point being that not every student will get the same clinical experience. That's true for every school of nursing, undergraduate, graduate education. And so by creating these simulations, you're kind of standardizing the experience of the kind of the core competencies and like the most critical aspects, so that you're ensuring everyone gets that knowledge and experience to develop that skill set. So let's talk a little bit about the curriculum and the degree options, and how much of that simulation is in person, and how much would someone need to come to campus for our program.
So our students, unlike some others, that our program is online in terms of a lot of the core courses are all online. But when they start their clinical sequence, we do both online classes as well as times that they come onto campus. And we do multiple simulations. Most often our students start in the summertime. So we have a first sim in the summertime, which is kind of the kickoff, which is something that everyone is somewhat acquainted with because we require that they have ACLS training. So the simulations that we start with are around scenarios that they would use their ACLS skills for. And then the next time we get together, we do a skills workshop where they come in and they do central lines in the early fall. They'll do central line placements, chest tube placements, intubation, A lines, things like that. And then in November, we come back after we've done shock in our didactic sessions, in our videos, and also in the readings and so forth. They come to the simulation lab to apply those skills, and they have 4 shock scenarios that they have to work through, figure out what kind of shock they have, and treat it appropriately. In the spring semester, we build on that again, and we do cases that have to do with more complex issues, like patients who have cancer and maybe develop a complication, or it might be an ethical scenario where it's an end of life and we're concerned about what the quality of life will be for that patient at the end of that time, and how to deal with that kind of situation with the patient and their family. And so they do that kind of simulation, and that builds for their final evaluative simulation that we do at the end of the semester, where they are the only person who's making decisions about the patient in the simulation setting. And they're showing us their skills, what they have. And we've helped them each time we've gotten together in sim with discussions and feedback and the scenarios that we do to basically scaffold until they are able to be completely successful and fly on their own when we get to the end of our simulation. So we do lots of simulation, and we have several workshops. In another workshop that we have in the early spring and we just finished, is lumbar puncture, thoracentesis, and using ultrasound to do exams at the bedside. So some of them are called EFAST exams, and they're used in trauma a lot of times.
Okay, and so you mentioned that a lot of the courses are online, but if someone was interested in our program, do they have to live locally to GW?
Yeah, and that's what's a little bit different about our program. We really like to be able to get together with our students and see how they're doing, and also make it easier for them to come in for these simulations and so forth, rather than traveling a great deal of time. So in that last those 3 clinical semesters, we require students to actually live within the DC metro area, someplace that's reasonable commute to the DC for our simulations, and to our Virginia campus where this main simulation lab is. We do have students that live sort of down towards Richmond and other areas that are farther out in Virginia, but the majority of our students do live in the DC metro area.
Okay, and then let's talk about the degree options, because back in the day, if you wanted to be a nurse practitioner, you got your master's degree, and now there are a couple of different options. So let's talk about what options you would have if you came to GW.
So we have a lot of options for people. We have the traditional master's degree option that usually people do part-time. It takes anywhere from 2 to 3 years to do it that way, because we like you to focus on and deeply learn the material in each of your subjects in the core as well as in the clinical semesters. We have a postmaster's certificate for people that may have gotten their master's as another kind of nurse practitioner and want to come back and get their acute care, their adult-gero acute care. And sometimes folks that have master's degrees in other things, but have in nursing, but have critical care skills. We also require 1 year of critical care experience before people come to us to start the program. And then our final option is a doctor of nursing practice. And people can come in with a bachelor's degree and go all the way through the program. The initial courses are surrounding the doctor of nursing practice, and you end with the 3 clinical courses with us in terms of becoming a nurse practitioner. So you're all set to take your certification exam, all 3 pathways when we finish up.
Okay. So another question students often have is how much do the faculty in this particular program actually still practice, and what type of experience do they have? So maybe each of you can answer that question.
Well, as I mentioned before, 26 years as a nurse practitioner. Many years of that I was working like half-time in a clinical setting and half-time in academia. I spent 2 years working as a hospitalist in Helen's Hospital a while back. And so I'm still practicing. I practice 1 day a week. We have another colleague who teaches with us who also is practicing 1 to 2 days a week. She works at the National Institutes of Health, in fact. And then Helen has worked for many, many years in the emergency department. And I'll let her tell about her experiences at this point.
I mean, it's been all, once I accepted the job, it's been all in the emergency department. And as I said, I've watched this emergency grow from a rather, I won't call it a mom and pop shop, but a very a good ED that was meeting the needs of a community. And as the community grew, the hospital grew, and as the ED grew. And so indeed, as I said, we now see approximately 100,000 patients per year, which is a busy emergency department. I've seen the provider group that I worked for grow. I've seen the oldies but goodies retire now, and the young guys grow into the ones that are running the practice. It's been very interesting over these past 24 years. But I was in my career, I was full-time nurse practitioner, and that was what I always called my vocation. And my avocation was my teaching. And so I got into education back on the graduate level in 2004, and have been teaching in acute care adult gerontology now, but acute care NP program since that time. So indeed, I think that one of the things that helps the communication of knowledge to the students is the fact that you have an active clinical practice, and that you bring a certain degree of expertise, so that in the three of us that work together in our current program at GW, we bring a very interesting skill mix to the students of people and the way we have been active. I bring the diagnostic reasoning. How do you take a problem and look at what the person is saying to you and tease out the information so that you can develop differential diagnosis? And how does that lead you to diagnostics interventions, and where do you go from there? Linda brings that expertise from the cardiology perspective, and then Nancy brings in that wonderful infectious disease and really the very high acuity critical care that she does over at NIH. So she brings that whole entire perspective to it. So we're an interesting mix of the professors. And as I will be quite honest to your audience, say that I will be honest and say I probably learn as much from my students as I hope my students learn from me. I mean, there isn't a cohort that goes by that I don't learn something from every single one, and practically every one of our collaborative sessions that we get to go through, hold every single week to discuss cases and things like that. There's probably something I walk away with. This is a new tidbit of information. So it goes back to my philosophy of the lifelong learning, that you will be a better provider for the learning.
Right. And the other thing I was thinking about as you were talking is kind of the art and the science of nursing practice and advanced practice nursing. We can teach you the technical skills, but what the stories that you guys have both shared, and the, particularly beginning with simulation with interviewing, you have younger generations that don't have quite as many interpersonal skills, and that's not true for everyone. Doesn't matter how old you are, you can not have that ability to interview someone to tease out that information. So I think it's great that our program blends the art and the science, because you've talked about both of those. So let's very briefly, Linda, if you'll tell me kind of what typical salaries are, and then if someone's interested in our program, how they can get in touch with us in our last few minutes together.
So the salaries are pretty good. Average salary, according to ZipRecruiter in January 2023, was 108,000, and then it ranges from about 96.5 to 132,000. And when you're living in more urban areas and suburban areas, so it might be a little higher than as you branch out farther. And again, depending on the acuity of the hospital, the size of the hospital, or the setting that you're in.
Okay. And so if someone was interested in our program, what would be the best way for them to move forward?
So the very best place to go is to go and explore our website at nursing.gwu.edu, and you can click through the various options of the various programs that we have, and you can look at the program study, etc. And if you have questions and you want further details, you can contact me directly. Call me in my office at 202-994-6259, and I would be happy to talk to any of you You can email me as well at Briggs10, that's BRIGGS 10 at gwu.edu. And I hope to hear from some of you.
Okay, well, thank you both for being with me today and talking more about what adult gerontology acute nurse practitioners do, and particularly the George Washington University School of Nursing's program. So thank you both very much for being with me today.
Thank you for having us.
Today's episode of This Is Getting Old, Moving Towards an Age-Friendly World has been sponsored by the George Washington University School of Nursing. Thank you for tuning in to This Is Getting Old, Moving Towards an Age-Friendly World. I'm your host, Melissa Batchelor, and if you'd like to learn more, you can check out my other episodes on my YouTube channel by subscribing and ringing the bell to get immediate notifications when new content comes out. In addition, you can also find the audio version of the podcast on Amazon Music, Spotify, iTunes, and Stitcher. Please feel free to leave an honest review because more reviews mean more awareness of the podcast and helps us move towards an age-friendly world. If you have a comment or a question, you can visit my website, melissabphd.com. Go to the Contact Melissa tab, and you can leave me a voice message. You never know, it might just include your question or your comment in an upcoming episode.